So we're going to talk about preparation for awake intubation. Now, first of all, we're talking about preparation. We're not talking about local anesthesia, okay? We're not talking about blocks. We're talking about preparation of the entire patient. The problem I see nationwide, especially when I give this lecture at the ASA, and I see the problem over and over again. When we talk about awake intubation, people have tunnel vision. They have tunnel vision for the blocks, okay? And they do really bad jobs at awake intubation. And the reason why they do bad jobs is they have tunnel vision. We have to prepare the whole patient, not just the blocks for the airway. Preparation does not mean block or topical anesthesia. We're also talking about awake, okay? We're not talking about snookered, zonked, Glasgow coma score of 3 patient. We're talking about a patient who maybe has sedation, but can cooperate with us. It'd be nice if they have amnesia, but the most important thing is that they can control their own airway and they can cooperate with us. And we're talking about awake intubation. We're not talking about fiber optic intubation, flexible fiber optic intubation. The flexible fibroscope is one tool that we can use. But any one of the tools that you can use with a patient asleep, you can also use with the patient awake. Okay? It's not limited to just a flexible fibroscope. We're going to look at this in a 6-finger model. What are those 6 fingers? Explanation, desiccation, dilatation, topicalization, sedation, and procrastination. My favorite. So what is explanation? What does Mickey say? Mickey says safety first. Patients understand safety. When you're decided that you have to do an awake intubation, typically you're worried the patient's going to reject this idea of being intubated awake. Patients come to your OR, and especially the pregnant patient, more than anything else, they want to be safe. They want the baby to be safe. That is their top of their mind. If you talk to them in terms of, we are going to do this, so you and your baby can be safe, patients will accept awake intubation. In my entire career, 22 years, I've had one patient normal cognition, refuse awake intubation, and this was a buff, healthy, young firefighter, okay? The guy just would not accept it. But other patients, if you talk about it in terms of safety, they will accept it. What do I say to patients? I say your anatomy differs a lot from the normal patient, and they usually know that. I mean, usually they have a tumor or they're morbidly obese, or I've had some Pierre Robin sequence patients in OB. They know that they have different anatomy. I need to take a look with an instrument. We're going to take our time. We're going to make your throat numb, like the dentist does, but unlike the dentist, I'm going to use needles. I'm not going to use needles if I can avoid it. Desiccation. Use a drying agent. Saliva is a barrier to topical anesthesia. Saliva coats the mucosa. It stops your local anesthetic from hitting your mucosa. It protects it. It dilutes your local anesthetic. And the more you manipulate their mouth, the more secretions they're going to produce. They're going to wash it away. This is a airway that has not had any kind of desiccation. You can see it's going to be very difficult to topicalize this patient. There's just so much secretion in that airway. Secondly, secretions are going to obscure vision with optical devices, whether we use a fibroscope, glide scope, air track. It's going to obscure our ability to see. And it's going to stimulate the larynx. We're going to get more laryngospasm, we're going to get more cough as that patient produces more secretions in the airway. We're going to use a drying agent. My favorite, 0.2 to 0.4 milligrams glycopyrrolate, intramuscular or intravenous. We have to start early. This is a picture of our holding area. I'm going to give them the glycopyrrolate in the holding area. If they don't have an IV and the schedule is tight, I'll give it to them IM. Because by the time they get to the OR and by the time they get their IV, they'll be dry. So we're going to dry up our secretions, and then we're going to use our topical anesthetic. Dilatation. Dilatation is a reminder to me, to tell you, to always prepare the nose unless contraindicated. Okay, and of course in pregnancy it's going to be contraindicated. No matter what the planned route, we're going to prepare the nose. Why? Local anesthetic that's in the nose will eventually reach the pharynx and the trachea. It's going to help you out. 2, it can be done while you wait. While you're waiting for the patient to get dry with your desiccant, you can start on the airway by preparing the nose. Most importantly, if you have a plan change, if you start to do an intubation through the mouth and you have difficulty and you haven't prepared the nose, you're going to have to start all over again. And most people don't start carefully. They go right for the nose, they cause pain, they cause bleeding. If you start to prepare the nose early, and always, if not contraindicated, you're at an advantage. This is a nose that has not had a vasoconstrictor. You can see there's not much room to work. It's wet in there. It's boggy. This is a nose that actually the same patient who's had Afrin. And you can see there's a lot more room to work. There's a lot less edema in that nose. We're going to be able to get through that nose. Why? We could intubate him through the nose. We can intubate him through the mouth. Why would we choose to intubate through the nose? Why might we choose to intubate him through the mouth and avoid the nose? Why? Why via the nose? Why would I even consider it? Well, it's actually an easier course. Fiber optic intubation is actually easier through the nose. It's easier to make this line, this black line, as opposed to making coming through the mouth and going down. There's reduced gag. If I'm intubating through the mouth, I come up against the pharyngeal wall before I make that turn, and there's more stimulation of gag on the pharyngeal wall. If I'm going through the nose, I'm hitting the nasopharynx and I'm skirting that pharyngeal wall. I have less gag with the nasal intubation. No oral aperture. Let's say I'm dealing with a patient who's got trismus, or their mouth is wired shut, or they're having dental restoration, or something with their jaw, and the surgeon's working in there. I might have no choice but to go through the nose. Why not? Why would I rather avoid the nose? Well, bleeding. Okay, this is the principal problem. That if I nick something in the nose, and that's of course the situation in the pregnant patient, I am bleeding and I may have no other devices that I can use. Pain. The only time I've seen pain in a patient having an awake intubation is when the nose was not properly prepared. And challenge. It's actually more of a challenge to intubate through the mouth than through the nose. And if I'm going to keep my skills up, I'd rather do it through the oral route just to keep my skills up. Topicalization. So people are always concerned about how they're going to block these airways. What's the right block to use for a fiber optic intubation, for an awake glide scope intubation? I am very consistent. I do the same blocks for every single airway, every single awake intubation. And what I say is plan 3 blocks. 3 separate blocks, you're going to cover 3 separate areas. The nasal area, the oropharyngeal, laryngeal area, pharyngeal area, and the hypopharynx, larynx, and trachea. And I'm going to start these blocks primarily in the holding area again before the patient comes to the operating room. We're going to look at this in terms of nerve supply, location, and the effect we're trying to block. So the nerve supply for the nasal area is the trigeminal nerve. The location is, of course, the nasal mucosa, and we're trying to block pain. If we look at the nasal mucosa, the innervation is by the anterior ethmoid nerve for the anterior 1/3 of the nose, and by the lateral nasopalatine nerves for the posterior 2/3 of the nose. And notice that this nerve also pierces the hard palate so when we start blocking the nose, we're going to start to get some oral cavity block. And also, I don't show it here, but there can be some cross innervation down to the pharynx. So by working on the nose, we're already getting the pharynx. It's okay, we're waiting for our glycopyrrolate to work, we're waiting for our desiccant to work, so why not? Why not go for the nose? I like to take cotton swabs. I fill them with whatever lidocaine I have available to me. Right now, I don't have 5% lidocaine ointment available to me, which was my favorite. So I'll use 2% viscous lidocaine or a gooey, what's the word I'm looking for? I guess viscous lidocaine. And I'll just put those swabs in the nose, following the floor of the nose, until I come up to the sphenoid bone where my lateral nasopalatine nerves are coming. As I said, my favorite is 5% lidocaine ointment. I'm having trouble getting that right now. I'm using viscous lidocaine, just as good. So that takes care of my nose. Now, hopefully, I've said to my patient, is your mouth feeling dry, cottony, tacky? Yes. If it doesn't, I give them more glycopyrrolate, and I'm forced to wait a few more minutes. So I'm going to go after the oropharyngeal area. Now, it's the glossopharyngeal nerve, branch of 9. The location I'm trying to block is the posterior pharyngeal wall and the posterior 1/3 of the tongue. This is where gag lives, and that's really what I'm blocking, gag. And if we look at the mouth and we look at the palatoglossal arch of tissue, that first arch of tissue when you look at someone's mouth, the nerve can be accessed right at the base of that arch. And I'm going to take my cotton swabs, but I'm going to use new cotton swabs, okay? And I'm going to put them right against the base of the tongue where the tongue meets that palatoglossal arch. And I'm going to do it bilaterally. Again, I like to use 5% lidocaine ointment, but if I don't have it, I'll use whatever lidocaine I can get. And about 50 milligrams per side. And actually, I forgot to mention it, but in the nose, I also use about 50 milligrams per side. Usually on the packaging, it's very easy to calculate the dosage. So far, I've used 200 milligrams of lidocaine. I can pull the tongue to the side, and I can put my lidocaine, here's my stick and my lidocaine, right up against that palatoglossal arch. By the way, I failed to mention the reverse side of your card is the cheat sheet for the 6-finger technique, okay? So now we're going to turn to the last area, the hypopharynx, larynx, trachea. It's the vagus nerve. The location is the hypopharynx, larynx, trachea, and we're trying to block laryngospasm and cough. And I'm going to do this with a technique that was taught to me by a pulmonologist. I'm going to take a syringe of lidocaine, viscous lidocaine solution, whatever you can get hold of. It's a syringe with a plastic catheter. I'm going to hold that catheter up to this patient and say, this is not a needle, it's just a catheter. It's just a piece of plastic, and I'll show them it's floppy. And I'm going to drop that lidocaine on the very, very base of the tongue, let it drip down, and aspirate. Now, why is he aspirate? Because I'm still holding his tongue, okay? And if you pull someone's tongue forward, they can't swallow. So anything I put back there is going to bathe their hypopharynx. It's going to hit their cords. They're going to aspirate it. You're going to start to anesthetize their larynx and their trachea. If you don't hold their tongue, they're just going to swallow it. They're going to swallow most of it. So far, we've used 300 milligrams of lidocaine. Now, there are other ways to do it. This is the, do you guys have the magic atomizer? This is a nice little device. It's a plastic tube that goes onto a syringe, and it's flexible and it's malleable. And this is another way to just spray lidocaine onto the cords. It's kind of a nice little easy technique, once again holding the tongue out. Another technique, if I'm using a fibroscope, something I like doing is called the Ovasapien catheter. You'll notice that's the second time I've used the name Ovasapien today. Andy Ovasapien is one of the fathers of difficult intubation in the United States. So I'm putting an epidural catheter into the working channel of the fibroscope. So it comes out the end, and it's a way for me to deliver local anesthetic. And the advantage of this is that I can actually see the whole larynx, and I can deliver local anesthetic exactly where I want to deliver it. It's a nice little technique. Here's someone with a stenotic airway, and what I'm going to do is I'm going to push that catheter through the airway. And I'm actually getting local anesthetic into the trachea even before I pass my fibroscope in there. So this might be a little added technique we can do, especially with a patient who's still coughing a little bit. So that maybe 80 to 100 milligrams of lidocaine. So far I've used 380, 400 milligrams of lidocaine. Other techniques, this is that magic I talked to you about that's malleable. You can change the shape of it. If I'm doing a glide scope intubation, not a fibroscope awake intubation, I can shape it to the size of the shape of the glide scope. Here we go. We're going to see a magic come in now. And I can just spray local anesthetic where I want it. You can't see it's being sprayed out, but it's a very fine aspiration, atomization. Intubating LMA, I can use it through the orifice of an intubating LMA. Various things that you can do, a nice little tool. So about 380 milligrams of lidocaine so far. Now, I want to talk briefly about toxicity. You'll notice I've talked a lot about lidocaine, but you can use virtually any local anesthetic that you want, okay? Benzocaine, some people use tetracaine, But what we should do is we should make sure we know how much we're administering to the patient, like any other drug. I like lidocaine because it's easy to calculate how much I'm giving. In this case, I've given 400 milligrams, 380, 400 milligrams. Let's talk about toxicity. A study looked at the application of topical anesthesia to the airway of 400 milligrams, just swish and swallow, putting some in the nose, putting some in the mouth. And what they found is if they measured lidocaine levels after an hour, they had a lidocaine level of 0.5 micrograms per ml. They took their toxic level from the literature at 4 mics per ml. They did not want to get above 4 mics per ml. They then applied 800 milligrams of lidocaine. Same thing, nose, mouth, let the patient swallow it, let the patient spit it out, and they got a blood level of 1.8 mics per ml, still well below the toxic level. Then they used an atomizer. Okay, has anyone ever seen an atomizer being used? Okay, so they used an atomizer, and they started off the atomizer with 400 milligrams of lidocaine, and now the dose got to 2.8. So they're starting to get close to the toxic level. And if they used 800 milligrams, they actually got a super toxic level, okay, a dangerous level. So here we have the same doses of lidocaine administered by topical versus atomized. The atomized technique is a good technique. A lot of people use it. This is one reason why I've abandoned it, okay, because there is a higher risk, and especially if you have a sick patient, someone who's toxic, febrile, higher risk of getting a toxic level or dangerous level. The second reason I've abandoned it is because when you use an atomized technique, you are getting that anesthetic agent all the way down to the alveolus. Every part of the bronchial tree has been anesthetized. God forbid your patient does aspirate, they're going to have zero cough reflex. There's no way to get that stuff out. So I've abandoned. It's a fine technique. A lot of people use it. For myself, I've decided not to use it anymore because of those two reasons. Invasive blocks, absolutely useful. I find they're rarely needed if you take care with your topicalization. Not always practical in the worst airways. We saw this lady before. We're not going to be able to do an invasive block in here. Sedation. So I mentioned Andy Ovasapien. Okay, this is Andy. Unfortunately, we lost Andy last year. Father of the Society for Airway Management, and just a very, very great guy and a wonderful teacher. What did Andy have to say about sedation? He said, quote, "When planning sedation for awake intubation, the patient typically requires less midazolam than the anesthesiologist." Okay? We get so nervous about awake intubations, but it's our anxiety. It's not the patient's anxiety. We don't want to overdo it, and we have to realize that we're doing it in terms of safety. Just do it. Okay? I mean, it's really, we need to chill out and just say, look, we're doing it because the patient needs it. And if we take our time, screw the schedule. I'm going to do a careful job because I'm talking about safety. I'm talking about this patient's life. Variety of agents. You can use anything that you want. Opioids, benzodiazepines, dexmedetomidine, droperidol, haloperidol, propofol. There are some general rules. Use judicious titration. Don't bolus the drugs like you normally give. You're trying to maintain consciousness. You're trying to maintain spontaneous ventilation. Mix as few agents as possible. Don't get into polypharmacy. If things go wrong, you can have a much harder time with it. Have reversal agents available. Have flumazenil. Have naloxone available. Again, if you get into trouble, you're going to need those agents. Dexmedetomidine. Is anyone using dexmedetomidine? Do you know about it? Very popular ICU drug. Very good for sedation in the ICU. Alpha-2 adrenergic receptor agonist gives a sleep-like state. Patients look like they're asleep, and in fact, the physiology may be very, very similar to sleep. Actually, the physiology of general anesthesia is very similar to sleep, but there's no respiratory depression. So you can take a patient with sleep apnea, they won't have any, they'll won't have terrible snoring or obstruction, I should say, using dexmedetomidine. The dosing is a little bit difficult. You have to bolus it. You have to give 0.7 mics per kilo over 10 minutes. If you bolus it too fast, horrible hypotension. I've seen it, ain't pretty. Infusion 0.2 to 0.7 mics per kilo per hour. Here's the problem. I'm gonna go back to dexmedetomidine. the problem is with dexmedetomidine is that there's a lot of literature out there saying this is the cure for making awake intubation easy. Okay, I've done it several times. It requires other drugs. It requires benzodiazepines. It requires narcotics, opioids with it also. And the people who say to you, I can do anyone awake because I'm using dexmedetomidine, what they're really doing, I'm convinced, is they're doing general anesthesia with a spontaneously breathing patient. Okay? Patient's asleep but still breathing. That's a different technique. That's not awake intubation. You wouldn't do that with a patient with a full stomach. Okay? When we talk about awake intubation, we're talking about patients, as we said, who can cooperate. Maybe they're amnestic, but they can control their own airway. So don't be convinced. If someone says we're just going to do it with dexmedetomidine, it's not necessarily awake intubation. It can be used as a sedative. It can be used, and not just but keeping the patient, aware. Procrastination. Awake intubation is not a rush job. If you decide to do an awake intubation, you decided because of safety. If safety is the issue, then nothing else matters. For example, the pressure of the operating room. Start preparation outside of the operating room. I call this the holding area before. This is actually the admitting area. I do my explanation in the admitting area. I may even start I'll do my dilatation in the admitting area, my glycopyrrolate in the admitting area. Topical anesthesia, I'll do in the holding area or directly outside the operating room. If someone complains that you're delaying the case, you've already gotten started. You're already doing your preparation. If someone complains about safety, ask them if their dentist monitors when he injects local anesthetic and epi into your gums. I think this is perfectly safe to do, and the model is dentistry. Dentistry does this all the time with injection. You're just doing topical anesthesia. I will not bring the patient in the operating room until they will tolerate an oral airway. Okay, oral airway at least 2/3 of the way in the mouth before I will let them go through the door into the operating room. And just this is showing him, we're actually still in the holding area here, and he's tolerating the oral airway. If I'm doing invasive blocks, we didn't talk about invasive blocks today, but if I am doing invasive blocks, someone insists on using needles, I'll do that in the operating room with good monitoring.